What I'm going to do in the next around 30 to 40 minutes is give an overview about the strategies employed in optimizing glioma surgery. Now, all of us neurosurgeons, even if we are not neurosurgical oncologists, treat gliomas, and these are the commonest tumors that all of us would encounter in our practice. It's this is basic textbook teaching that surgery forms the basic keystone for treatment of gliomas. There are diagnostic benefits, there is symptomatic relief to offer. Of course, it provides tissue for research and it facilitates adjuvant therapy. However, the basic and the most important benefit of surgery in gliomas is the oncological benefit. And that is because the extent of resection is an important prognostic factor in gliomas. If you look at the time-tested prognostic factors, and these remain true even today, it's the age, the performance scale of the patient, the molecular profile, and the molecular profile has emerged as a very important prognostic factor in the last decade. In addition, the adjuvant therapy and the extent of resection. And if you look at these factors, you realize that the first three are innate and inherent, and you really can't do anything about that. What can be modified is the therapy, the adjuvant therapy, and the extent of resection that you can offer to these patients. And as neurosurgeons, it's quite incumbent on us to optimize the extent of resection, which is directly within our hands. Extent of resection is an marker for both high grades as well as low grade gliomas. And this has been proven repeatedly over years in various trials. There has always been this controversy as to how much should we resect, whether it should be a GTR and whether a non-GTR has any oncological benefit. There are many studies showing contradictory results. However, I would like to quote this one study, which is a very elegantly done study, which looked at the extent of resection and provided a survival modeling, in which they showed that for every incremental improvement in the extent of resection for a given combination of prognostic factors, say for example, you have an age of 50 and you have a KPS of 90, and you have a treatment, adjuvant treatment of temozolomide and radiotherapy given to the patient. If the extent of resection in that combination of prognostic factors increased from say 60 to 70%, it resulted in an increase in the survival of that patient. And this was true for all combinations, which means that given any of the other prognostic factors, increasing the extent of resection, any patient has an incremental benefit in the overall prognosis, which means the more you resect, the better. 70% is better than 60%, 90% is better than 80%. Not only that, but of late, we've also known now that extending resections even beyond the so-called 100% resection, GTRs, that is by including the non-contrast enhancing T2 flare components in glioblastomas, for example, itself has a prognostic value. The bottom line is that you have to resect them maximally, because the oncological benefit of any treatment, and in our case it's surgery, which directly impacts the long-term survival and quality of life, is very important. However, with surgery, and this is specifically very important, you have to balance that with the procedural efficacy, which is the perioperative outcome, and that reflects on the short-term quality of life of these patients. And therefore, we always have to play this balancing act of maximizing resection and preserving function. Safe maximal resection remains the underlying guiding principle of surgery for gliomas. During routine glioma surgery, all of us employ general microsurgical techniques, and we estimate the completion of excision based on visual cues. And this is how we gauge that we have achieved the goal that we set out to. However, there is a lot to be achieved still in optimizing this, using these, so to say, crude techniques while performing the glioma surgery. And why is that so? tumor boundaries are often difficult to discern and delineate, and functional areas are more often than not hidden and not obvious. And most of the times, there is a conflict between tumor boundaries and functional areas. We do assess eloquence based on preoperative anatomical as well as functional imaging. However, these have their limitations. And this has been elegantly shown, demonstrated in this paper, which gave the concept of presumed eloquence. Now, when you say presumed eloquence, you mean eloquence judged on the preoperative imaging, but not confirmed on intraoperative mapping. So in this particular paper, and this paper is from the San Francisco group of Dr. Mishberger, they had a series of 280 odd gliomas in which they had mapping performed in some, and they did not do mapping in some other patients. And they had judged based on MRIs whether these were eloquent or non-eloquent. So if you look at the table at the bottom, there was one group where they did not map at all. They thought it was eloquent, but they did not use mapping. And this is what they called presumed eloquence. They assumed they were eloquent and they did not map, and they went ahead and operated. And if you see, the survival was poor. Now, in the other group, they considered them eloquent, but they mapped them. And mapping helped them differentiate the ones which were truly eloquent from the false eloquent tumors. And interestingly, the ones which were truly eloquent did as badly as the group which they did not map based on eloquence. But the ones which were false eloquent actually did very well, just as the non-eloquent tumors would. Now, when you look at this group of mapping, you can easily make out that if they had mapped that group, then they could have actually split it into two groups which were falsely eloquent or truly eloquent, and could have had better outcomes for the ones which were false eloquent, which means that presuming eloquence based on preoperative MRI is fallacious, and you need to have confirmation intraoperatively. Now, coupled with this is the other important fallacy of the operative impression of extent of resection by a surgeon. Now, there are many studies which have demonstrated this. I'm quoting one of them, is that when you define your extent of resection intraoperatively, how correct are you if you do a postoperative MRI? And what this study showed, that in patients in whom surgeons had reported gross total resection intraoperatively, it was actually achieved in only 30% of the cases. In 70% cases, the MRI demonstrated residual tumor. And when they retrospectively reviewed the resectability of the tumors and the extent of resection, they realized that a complete resection was actually achieved in just the 1/4 of the patients which were deemed potentially resectable. This means that between your intent of surgery, your planned intent of getting a gross total resection, and the actual outcome, there is a lot of discrepancy. You might expect a resectable tumor to translate into a gross total resection. However, that does not always happen. And on the other hand, just like presumed eloquence, there is presumed unresectability. It's not necessary that all so-called unresectable tumors will have a non-GTR. Added to this is the problem of intratumoral heterogeneity, whereby a subtotal or a suboptimal resection runs the risk of inadequate tumor sampling, resulting in undergrading of tumors. And therefore, if you come back to this routine glioma surgery that we would generally perform, it is actually dogged by problems of erroneous histological sampling, overestimation of extent of resection, as well as eloquence. And therefore, it calls for a need to augment the human capabilities in order to improve the resection. And as I said, you need to bridge the gap between your intent and the outcome that you have wanted to achieve. And this can be done by a right combination of technique and technology. And this is what you would call as optimizing treatment or customizing surgery for gliomas. It starts with selecting the right case. Not all gliomas are resectable. We all know that. And therefore, a basic checklist before subjecting a patient to radical glioma surgery is very important. And I'm sure this is nothing new or technologically advanced. I would also like to emphasize here that the right technique of surgery is as important as is the use of appropriate adjuncts during glioma surgery. And microsurgical principles of glioma surgery are again not new. They have been described and they have been laid down years ago, and all of us are aware of that and follow these. However, I'd like to reiterate and reinforce these principles. These are based on the concepts of gyral and sulcal anatomy, also increasing and emerging information about the complex white matter fiber tracts and the patterns of spread of gliomas. Now, we all know that gliomas arise in the subcortical white matter and they spread along white matter tracts. And this has been described in Aliasgar's epic volume on glioma surgery. They respect the pial boundary, and this actually is the important principle of the concept of subpial resection. Now, the pia is integrally and intimately adherent to the glia limitans, which is the external lining of the gray matter. And together they form a very, very robust boundary, which is usually not breached by gliomas, even in the most malignant cases. If gliomas do spread, they spread within the white matter tracts from underneath the sulcal banks in the brain. And this is the principle of subpial en bloc resections, which is composed of course, localizing the tumor to the tumor-bearing gyrus, then isolating the tumor-bearing gyrus by performing subpial resection, maintaining the pia along the banks of the sulcus, and at the depths performing white matter dissection because there is no pial boundary at depth now. And this is a technique of en bloc resection which can be performed even for high-grade gliomas. The advantages of subpial resection include that it is anatomical, it ensures complete removal of the tumor-bearing gyrus or gyri, therefore it's a radical surgery, oncological. By preserving the pia all along the sulcal banks, it prevents inadvertent mechanical damage to the adjacent gyri, and it also protects the vessels within the sulci, which would be supplying adjacent gyri, which may be eloquent, and it does not interrupt the subcortical connections, except where you're going to be dissecting in the subcortical white matter, where subcortical mapping becomes important. And therefore, this is a safer way of performing glioma resections. And eventually, it's better than piecemeal resection because it's more cosmetic, elegant, and a simpler and efficient technique. So the concept of gross total resection, like a lesionectomy, is actually inappropriate. Even en bloc removal with margins, as is seen here, is probably a gross total resection, but it still leaves behind gyral tissue, which is actually non-functional and may only serve to be a substrate for future local recurrences. Therefore, an en bloc gyral resection is what is advisable in gliomas. And we know that the glioma may extend into adjacent gyri via white matter tracts, and therefore a multi-gyral subpial resection is also possible and can be done. And if you want to stretch this concept further to supraradical functional resections, that is also possible. In all cases, this has to be combined with mapping in the subcortical eloquent substrate. However, even while using meticulous techniques like what I just showed you, often one encounters hurdles. And there is again discordance between what you think you've achieved and what actually has been achieved. And therefore, you need to augment your human capabilities by the use of appropriate adjuncts. Now, these adjuncts are many, and I'm listed out a few of them here, and I will talk about some of them. There are adjuncts which are important for maximizing resections, and the others which are important for preserving function. Of those which help maximize resection, they are essentially tumor visualization and imaging techniques. These include static navigation, intraoperative optical imaging, and intraoperative radiological imaging like MRI and ultrasound. And on the other hand, you have complementary techniques of brain mapping, both under general anesthesia and awake. And we'll go through all of these briefly to see what role they play in optimizing glioma surgery. The navigation, we all probably use on a routine basis during glioma surgeries and many other neurosurgical procedures. And they are basically useful for planning the craniotomy, good for static targets, and therefore when brain shift sets in during intraaxial tumor surgery, they lose a lot of the accuracy. And therefore, the navigation is good for delineating the craniotomy and general planning and understanding the relationship of gliomas and their surrounding structures. But it's not much used as an accurate tool for guiding during resection control. Optical imaging in neurosurgery, again, there are a host of techniques which are used in neurosurgical procedures for optical imaging. Many have been described. Most of these have been tried out experimentally, but very few of them are used routinely. The one which is most often used is the fluorescence, and of these, the induced fluorescence is what I would talk about. So this is based on the principle of aminolevulinic acid, and aminolevulinic acid is a precursor in the heme cycle. It's synthesized endogenously in the body in all cells, and it goes through a series of transformations to eventually get converted to heme within the cell. The penultimate stage before reaching heme is protoporphyrin 9, and there is an enzyme called ferrochelatase which converts the protoporphyrin 9 into heme. There is a general deficiency of this enzyme in glioma cells, and the conversion of ALA gets arrested at the level of protoporphyrin 9. However, protoporphyrin 9 accumulation normally would cause a negative feedback and cause a stop on the heme cycle within the glioma cells. And therefore, if you load it or overload the body with ALA by giving an exogenous dose of aminolevulinic acid, then you override this negative feedback and result in an accumulation of excess of protoporphyrin 9 within glioma cells. And this is what produces the fluorescence, because protoporphyrin 9 is a fluorophore. And when used with the appropriate microscope and the right filters, it produces fluorescence, which is visualized as red color and is highly specific for glioma cells and allows resection of all the fluorescing tissue, even beyond contrast enhancing boundaries. And this was proven in randomized controlled trial more than 15 years back, which demonstrated a doubling of the extent of resection, or the GTR rate, from 38 to 64% in potentially resectable gliomas, and also showed a benefit in terms of progression-free survival, though the trial was not powered for survival analysis. The ALA fluorescence can be used for resection control, though there are many other benefits of using fluorescence. For example, ascertaining the adequacy of biopsy when you're targeting the highest grade in an unresectable glioma or a deep-seated lesion. It's also useful distinguishing viable tumor from treatment effects in recurrent gliomas, and may be useful, and people have reported its use in many other tumors as a marker for extent of resection and tumor delineation. And very exciting is the field of photodynamic therapy, where these fluorophores, when excited by a different combination of lights, can even result in cytotoxic effects, thereby can be used as an adjunct to surgery. On the other hand, there are other fluorophores, for example, fluorescein. This is not specific because it's not based on a metabolic phenomenon or a metabolic cycle, but it's based on the passive permeation from leaky blood-brain barrier. This can be visualized as a yellow fluorescence, often even with the naked eye. And there are many studies which have its use in gliomas. A word of caution that though this is cheap, it lacks specificity, and the timing of the injection of the dye and the visualization and the false positives that occur in the surrounding tissue, which may show blood-brain barrier bleach without actually, you have to be careful. It's very important to understand the mechanism of action before applying it during glioma surgery. The limitations of fluorescence is, of course, that you need to administer a drug like ALA or fluorescein. There is autofluorescence which works, but it's so faint and very non-specific that it can't be used clinically. It also needs modification microscope. And ALA, the predictive value is not 100%, though it's in the high 90%. The definition of visualized fluorescence quality is also not very objective. And this is because everyone's visual impression may be different. And applicability to other tumors is questionable, and one needs to use general neurosurgical acumen while applying these adjuncts, as it is for all adjuncts. What one must also remember, fluorescence is a surface phenomenon and does not tell you how much of tumor is present in the depth beyond the surface. And therefore, some kind of cross-sectional or tomographic imaging is also preferable. The best intraoperative imaging is the intraoperative MRI. There is no doubt about it. It's the gold standard and allows real-time intraoperative imaging. This has been shown in studies, systematic reviews, and even a small randomized controlled trial, though there are certain limitations in that RCT. However, what plagues the general application of intraoperative MRI is the extreme cost, the challenges in logistics, infrastructure, manpower, and the long acquisition times, which actually are counteractive in glioma surgery. On the other hand, is the intraoperative ultrasound, which again serves the same purpose and has certain benefits which actually may make it very, very attractive as a tool during glioma resections. In our own experience, and I have been using the intraoperative ultrasound for a long time, it actually serves as a guide for verification intraoperatively at multiple stages during glioma surgery, be it identification of the lesion, either for gauging the trajectory for reaching the tumor, or even for biopsy, for delineating the extent of resection, and for identifying the normal anatomy. Compared to intraoperative MRI, the intraoperative MRI definitely stands out in terms of image resolution, multiplanar imaging, and improved orientation of the image, because the ultrasound image is limited by the field of view, and sometimes the abnormal orientations or unconventional orientation, should I say, that it shows. There is, of course, the technique of navigated ultrasound, 3D ultrasound, which compensates for these problems. And if used, it can actually sort of neutralize these disadvantages. And on top of it is the benefit of being easy, quick, and being able to do it iteratively, repeatedly during surgery without loss of much time, and being cost effective, which makes this intraoperative ultrasound very attractive as compared to the intraoperative MRI. As a resection control tool, in our own experience, we found that the ultrasound is actually has influenced and modified our decision of intraoperatively going ahead with further resection in more than 40% of cases. In this study, we looked at the change in intraoperative decision prompted by the intermediate scan that we did while using intraoperative ultrasound. This was navigated ultrasound, and it showed that in most cases, it showed us a residue which we would have otherwise missed and led us to go ahead and do a resection. With a good diagnostic accuracy compared to postoperative MRI and concordance with the postoperative MRI in terms of the defined extent of resection, thereby bridging the gap between what I described, the intent of surgery and the final outcome that we wanted to achieve. Not only in our experience, but this has been shown in a large meta-analysis where they looked at intraoperative ultrasound and across gliomas, high grades, low grades, navigated as well as 2D ultrasound, and showed reasonable gross total resection rates, both in high grades and low grades. And if you look at ALA literature and the intraoperative MRI literature in terms of extent of resection, this is very, very comparable. There is, of course, no head-to-head comparison between the ultrasound and the MRI or the ALA, and the jury is still out in which is better, but these are equally useful in glioma surgery, I should say. As I mentioned, the 2D ultrasound, which is standard and which is used very often, is sometimes limited by the field of view and orientation problems, and navigated or 3D ultrasound can overcome some of these by allowing image fusion and co-display using navigation, providing multiplanar imaging, and allowing serial comparison of intermediate scans so as to be accurate in diagnosing the residual tumor. Also, it can compensate for brain shift. There are recent advances which allow the ultrasound to correct for the brain shift, and this can be potentially useful in navigation. However, not by itself, and therefore acquiring a good 2D ultrasound remains the basic principle even while using navigated ultrasound. We found it useful, as I mentioned, in all types of gliomas, and specifically low-grade gliomas which are non-enhancing, where ALA itself is a limitation, and the ultrasound is a very, very useful tool in delineating the tumor boundaries. And very importantly, we found that it combines well with some of the other adjuncts. With ALA, it is useful in being able to identify the non-fluorescing components of the tumors, and it fits in very well with awake surgery and intraoperative functional mapping and monitoring, because unlike the MRI, it's not logistically challenging, and it does not alter the surgical workflow much, and therefore is very friendly to the operating room, I must say. So as one piece of the wider multimodal intraoperative image guidance flowchart, the ultrasound, when combined with navigation, will actually complement each other and prove to be a very strong and powerful intraoperative guidance tool. We've been using the ultrasound for more than a decade, and we recently published this experience of 1,000 cases. And as I said, though we rely a lot on navigated ultrasound still remains the more often used modality in our experience. Though for resection control in gliomas, we prefer the 3D navigated ultrasound, which has helped improve the resection rates. So as I said, adjuncts are there for maximizing resection, but at the same time, we need to balance that with preservation of function. And this is possible with intraoperative mapping and monitoring. In the last 10 minutes, I'm going to be discussing various ways of intraoperative mapping and monitoring. So what is the benefit of intraoperative mapping? We saw few slides earlier the concept of presumed eloquence, where the preoperative assessment of eloquence may be erroneous, and intraoperative mapping and monitoring when employed can provide us the right and the accurate assessment of the eloquent location of the tumor. In this large meta-analysis, what was described was that by using intraoperative mapping, there was a transient increase in neurological deficits. However, late severe neurological deficits were reduced and extents of resection were improved even when more eloquent tumors were operated on, which means that you are able to improve the extent of resections even with increasing eloquence of the tumors. This risks a little bit increase in transient immediate postoperative deficits, which recover over time. And this is the basic pattern of postoperative recovery in most eloquent region tumors that we would see. So as I said, it's important to map intraoperatively because presumed eloquence can be erroneous. And as seen in this meta-analysis and many such studies, mapping improves the resection rates and neurological outcomes. So how do we evaluate the function intraoperatively? You could do that under anesthesia. It's an indirect evaluation by assessing electrical activity within brain circuits, giving controlled electrical stimulus at times, and recording spontaneous or induced potentials. It's excellent for motor and somatosensory. However, it does not allow you to map and monitor certain non-motor sensory functions, and there are a lot of them in the brain. And therefore, you have awake surgery, which has similar principles of delivering controlled electrical stimulus, but allowing you to map and monitor more functions. A neurophysiologist is useful and in fact crucial for complex intraoperative mapping under anesthesia, whereas a neuropsychologist and maybe even a language neurolinguist is preferable and useful during complex awake brain mapping. The systems, though common, can also be a little bit complicated when you use it under general anesthesia because you need many more channels and different modalities. Whereas for awake, what you need basically is a bipolar stimulator, and that's often possible as a standalone simple device. This is a basic overview of what can be mapped under anesthesia and under sleep in awake patients. As you can see, I said that you could map many more things and not just language, but even other cognitive functions, and I'll show them a little later in the presentation. Often there is confusion as to what are the modalities of stimulation when doing mapping under anesthesia and under awake conditions. Bipolar, monopolar, low frequency, high frequency, often a confusion. What I would say is that it's simple to remember that awake surgery is usually done with bipolar stimulator, which is low frequency, 50 Hertz. Though monopolar can be used, it's generally used as a high frequency train for motor mapping, even in the awake cases, but most often it's bipolar. Whereas under asleep, monopolar is preferable, which is a high frequency train of stimuli mapping, train of 4 or 5 or sometimes 6 and 7. Bipolar can be used under asleep also, and it's again the low frequency paradigm, but generally you need very high stimulus currents intensities to get responses, and that risks a lot of seizures when it is used under asleep conditions. So most often under asleep, monopolar high frequency motor paradigm is what is used. Between bipolar and monopolar stimulators, one important thing to realize is that the monopolar has a strong spread, circumferential spread of the stimulus, and therefore may be less specific. But this itself has a use in certain situations like the dynamic mapping I'll talk about. Whereas bipolar is more focal stimulation and is more useful for localizing and for mapping. When done under anesthesia, different modalities of mapping and monitoring are used. All of them essentially look at monitoring the functional integrity of the neural structures with the aim of preventing damage and ensuring that they are all right all throughout surgery. So the goals are to identify, that is to map the structure, and at the same time to monitor the integrity all along. And these are the questions that you have to keep answering during surgery, which is where the intraoperative mapping helps you. Now, all of this is based on the principle of action potential and how they are recorded and how they can be evaluated. The modalities that are used in IONM are recording spontaneous activity or recording induced or evoked activity. Spontaneous activity can be free run EMG or corticography, whereas induced or evoked potentials can be triggered EMGs, mainly used in spine and cranial nerves, and evoked potentials for brain and central conducting pathways. Triggered EMGs, as I said, are used for cranial nerves or spinal nerves, and essentially they use a stimulator, monopolar or bipolar, and recording the EMG from the respective muscles. On the other hand, evoked potentials for motor mapping include stimulation of the cortex either directly or via transcranial electrodes and recording the evoked potential from the final pathway on the muscle. The sensory pathways are recorded by way of SSEPs, where the stimulus is at the distal end, at the sensory organ, and usually the median nerve or the common peroneal, and goes up all the way through the central conducting pathways and recorded on the somatosensory cortex. Both of these ensure that the entire conducting pathway, right from the cortex to the distal effector or sense organ, is intact. Motor mapping techniques specifically under anesthesia are the monopolar techniques that I talked about. And as I already showed you, it basically involves mapping and monitoring the entire motor conducting pathway. The risk in brain tumor surgeries or glioma surgeries is mechanical injury to the pathways, and this can happen anywhere at the cortex level and subcortically. And also there is a risk of vascular insult. And this often happens when the motor substrates are actually far away from your site of surgery, for example, gliomas. But the vascular supply to the motor pathway through the lenticular striates, for example, is at risk. And therefore, both the mechanical and vascular insults need to be ascertained and prevented during glioma surgery. Therefore, intraoperative confirmation to identify the functional areas by direct mapping is important, as well as to ensure integrity by monitoring is important. Monitoring is usually done in a continuous fashion, and it is useful for both preventing or anticipating and preventing vascular and mechanical insults. Whereas mapping is usually done periodically in a punctiform way and can preempt only the mechanical injury by knowing that, okay, now you are close to certain important structures and you have to be careful or you have to stop. Knowing when to stop is very crucial. And this determines whether you can get a good resection and also whether you will induce a neurological deficit. And this has to be predicted reliably, and you should be able to estimate the consequence of this surgical intervention reliably. And this is the concept of continuous mapping along with monitoring. So what is the continuous dynamic subcortical mapping technique? It is based on the principle of a linear relationship between the strength of stimulation current and the distance from the substrate which is getting stimulated. And for monopolar, as I said, monopolar's radial spread has an advantage. That is, for every milliamp of current that you increase, the current dissipates 1 millimeter in the subcortical white matter. And based on this, you can gauge the distance from the corticospinal tracts. So if you stimulate at 10 milliamps and you get a response, you can be reliably sure that the corticospinal tracts are within 10 millimeters of your stimulation site. Based on this, a continuous subcortical mapping using a suction monopolar was devised and described by this group from Bern, Professor Abe's group, whereby using the subcortical, the suction, which was integrated with a subcortical stimulator, by serially reducing the subcortical, the current of the subcortical stimulation, they could resect layer by layer the tumor and reliably gauge the distance from the deeper subcortical corticospinal tracts and stop well in time, ensuring a radical resection as well as preventing neurological injury to the corticospinal tract. In our own experience, we found that this was very, very useful, and we were able to get radical resections in a large number of patients with tumors close to eloquent areas, close to motor eloquent areas, with no permanent neurological deficit. And these tumors were all very close to motor areas, either cortically or in the subcortical white matter. Moving ahead to the last part of the talk, as I said, the mapping and monitoring under anesthesia is very useful, but it has limitations in the kind of functions that it can let you monitor and map, and therefore awake craniotomy is the solution for mapping and monitoring those other important functions. The direct electrical stimulation used in awake surgery is a little different from what is used in routine mapping under anesthesia. As I said, this is a low frequency bipolar stimulation, and the exact pathophysiological basis is still not completely clear, but what it does is that it induces a transient disruption in function of the neural substrate, thereby demonstrating its function and allowing you to map that particular cortical or subcortical site. Therefore, besides stimulating, you also have to record or you have to observe the particular phenomenon. And interpreting that response is the key in determining whether you will designate an area as eloquent or not eloquent. In a successful awake craniotomy program, it's a teamwork, but one of the most important components of that team is the patient. And it is very important that discussions with the patient happen prior to surgery so as to gauge the confidence and cooperation of the patient and prepare them for the intraoperative process. It's very important to establish a rapport and a comfort level. It has to be, many things need to be checked prior to taking up a patient for awake surgery. That includes the patient's baseline status, the patient's expectations, and ensuring patient cooperation. The type of anesthesia that is used can vary either between a complete awake type of surgery where you give local anesthesia only with scalp block, or you put the patient asleep and secure the airway, laryngeal mask airway, as we usually prefer to do. And what we like to do is with the patient in the OT, we position the patient usually lateral on a horseshoe, and once the patient is positioned lateral in the horseshoe, we put in the LMA and then replace the horseshoe with a 3-pin clamp so that the lateral position is maintained in a position which the patient was comfortable with. Then we give the scalp block and complete the navigation formalities. And once the craniotomy is completed, the LMA is removed and the patient is awakened for allowing you to map. This is the positioning for the surgeries, both right and left-sided. As I said, it's important to have the entire team involved in this, and the patient is most important, and I'll say that again and again, and ensuring proper patient positioning is very crucial so that the patient's comfort is important during those 3-4 hours of surgery that they're going to be lying down. And therefore important to recheck everything after the draping to make sure that the patient is not claustrophobic and there is direct access to the face of the patient. The basic prerequisites for intraoperative testing are a simple bipolar stimulator and having a dedicated setup which may not be very complex, but have a fixed protocol of intraoperative tests that you would like to use, and administer the same test preoperatively to check how the patient's performance is at baseline. Patient has to be comfortably placed. Use a coordinated and synchronized stimulation and presentation of the task. The stimulation has to come a second before the test is meant to be able to correctly induce the deficit that you are looking for. Otherwise, you may have false negatives. And systematically map the entire cortex. This can be done manually, or it can be done automated, where you have and you can actually gauge where everything can be recorded. That's very useful for bringing everything together. Remember that you have consistent responses, preferably 2 to 3 times in the same area, but don't overstimulate, otherwise it can cause seizures. And always keep testing the wakefulness of the patient. We do a simple reaction time testing. The first thing to be done is to set the threshold using a motor response or speech arrest, and then go on to doing subcortical mapping, cortical and subcortical mapping using the same threshold. You have to remember to map and monitor in between the mapping, because mapping is intermittent. And you have to interpret the responses well, because different responses can happen for the same test at different locations. And it's important to know which areas are redundant and which ones are very, very important, because it is based on the concept of brain plasticity, which is a complex interplay of interconnected networks. There are certain areas in the brain which cannot be sacrificed. These are sacrosanct, and all of us are aware of that. The primary sensory motor, the ventral premotor cortex, the classical language areas. However, very importantly, there are many subcortical facts which are important and which can be missed if subcortical mapping is not done. And these include the projection fibers and the large association tracts, as well as the inferior fronto-occipital fasciculi. The range of tests that are used is wide, and this is just a snapshot to show what is possible and what can be done. However, the factors influencing the selection of tests depend on where the tumor is located, what is the patient's preoperative performance, and therefore a neuropsychological assessment is crucial, and what is the expertise of the team performing the surgery. Generally, we use this combination of tests which are simple and which are done routinely. We add some of the more complex tests for certain specific locations, or depending on the patient's profile and the expectations. Essentially, all of these tests are used in most of the awake surgeries, and they are something which our team and our setup, all our team members are very used to. This actually summarizes my talk on the optimization of surgery based on mapping, monitoring, as well as intraoperative adjuncts to improve resection. Thank you very much.